Hello and welcome. This video is about hysterosalpingogram, a procedure used for investigating female cases of infertility. X-rays have been around since 1895, and the first hysterosalpingogram was done in 1914. Over the years, this procedure has become safer and more effective. The learning objectives we hope to achieve in this video include the indications and the contraindications for hysterosalpingogram, the technique used for this procedure and the requirements, how patient is prepared, how do we interpret the findings, what are the alternatives to hysterosalpingogram, and what is the recent evidence about hysterosalpingogram. So, a hysterosalpingogram, or an HSG, is a radiological procedure used primarily to evaluate the fallopian tubes and the shape of the uterine cavity. It is performed as part of an infertility workup to determine whether blockages or structural abnormalities are contributing to infertility. This test may be complemented by another procedure with other imaging modalities to further evaluate infertility. In which situations should we do a hysterosalpingogram? So this is indicated if there is a condition of infertility, if there is recurrent pregnancy loss, to see the uterine cavity, to exclude Asherman's syndrome, if you suspect tubal occlusion because of a history of pelvic inflammatory disease or endometriosis, a pre-evaluation before certain gynecological surgeries, and suspected uterine abnormalities, for example, congenital abnormalities, fibroids, and polyps. There are certain contraindications for this procedure, and these include if a pregnancy is suspected, or if there is an ongoing pregnancy, if there is a current history of pelvic infection, or if there is a current history of very heavy uterine bleeding. So a hysterosalpingogram should never be done if the patient is spotting or bleeding. It is also contraindicated in the second half of menstrual cycle. This can be calculated very easily in patients who have a regular menstrual cycle of between 28 to 35 days. But in patients who have an irregular menstrual cycle, which is either short or which is very long, then it is better if it is done in the early follicular phase to help avoid potential overlap with an otherwise viable gestation. An additional benefit of doing this procedure in the first part of the menstrual cycle, or in the proliferative or in the follicular phase of the menstrual cycle, is that the endometrial lining will be very thin. And this will help to understand the images that are made with the procedure. Past history, the normal findings of hysterosalpingogram reveal the contrast filling the uterine cavity uniformly and flowing freely through both fallopian tubes, spilling into the peritoneal cavity, indicating patent tubes and a normal uterine shape. A fluoroscope will easily show the flow of the dye in the uterus and the tubes. In case the fluoroscope is not present, static films will be taken firstly as a contrast image before the introduction of the dye, then at the time of the introduction of the dye, a few minutes after the dye has been introduced, and then 10 to 15 minutes later. This helps to ensure that the false negative results are reduced. In case there is a tubal spasm at the time of insufflation of the dye. So this is an image, a static image of hysterosalpingogram being conducted, and the red dot here is showing the uterine cavity, and the dye has been introduced into the uterine cavity, and then the dye can be seen to flow into the fallopian tubes on the right side and on the left side, and then start spilling through into the peritoneal cavity, here as well as here. So as you can see that in this particular case, in both the fallopian tubes, the dye has been pushed outside into the peritoneal cavity. However, one must remember that 10 to 15% of cases in which a hysterosalpingogram has been done, there is a chance of a false negative report. And this is because of the presence of tubal spasm in the tube. So if a patient has a negative report, then it means that the patient has to be evaluated further to identify, firstly, whether the tube is indeed blocked, and secondly, to identify the reason for the blockage of the tubes and to see if there is any other damage in the pelvic cavity. Abnormal findings on hysterosalpingogram will include tubal blockage, in which there will be no spillage of contrast from either one or both fallopian tubes. This suggests tubal obstruction. The blockage could be proximal, that is near the uterus, or it could be distal, near the fimbria. In hydrosalpinx, the fallopian tubes are dilated and filled with fluid. This is a condition often associated with tubal damage and infertility. The uterine cavity is also evaluated with this procedure. We can identify the shape and the structure of the uterine cavity. It helps to detect congenital abnormalities such as a septate uterus, fibroids, polyps, adhesions in the form of synecdoche, or scarring that might affect implantation or pregnancy maintenance. And be prepared for the procedure. This is typically scheduled during the follicular phase of the menstrual cycle, between days 7 and 10. The patient should not be menstruating at the time of the procedure, and the menstruation should have stopped for at least 2 days, after which the procedure can be performed. So the reason for performing it in the follicular phase is that we can avoid performing it during pregnancy, and also at this time the endometrium is thin, so the interpretation of the procedure and the static films or the fluoroscopy is very good. The patient should preferably avoid intercourse before the procedure, or she can use condoms reliably. Patients may be advised to take a mild pain reliever or a non-steroidal anti-inflammatory drug such as ibuprofen 30 to 60 minutes or 1 hour before the procedure. This will not take the pain away completely, but it will minimize discomfort or cramping. Antibiotics may also be given as a short course to protect from infection. This depends upon the health system within which the patient is having the procedure. The equipment typically required during a procedure includes a speculum, a fluoroscopic table, betadine solution for cleaning the cervix and cleaning the vagina, a long tenaculum to hold the uterine cervix, and a cannula for dye administration. A metal cannula with a rubber Aqorn tip, or a plastic catheter with an inflatable balloon, or thin catheter and a shallow Aqorn may be used. The procedure is performed in a radiology suite by a radiology technician. However, an OB/GYN clinician can also perform the procedure in the office or the clinic setting. In most cases, only a single operator is required to perform this procedure. It's on an X-ray table in a lithotomy position. A speculum is inserted into the vagina to visualize the cervix. The cervix should be cleaned with an antiseptic solution, and a cannula or a catheter is gently inserted through the cervix into the uterine cavity. A tenaculum is used to manipulate the uterus if required and to ensure complete visualization during the radiography. A radio-opaque contrast dye, which is usually water-soluble, is slowly injected through the cannula into the uterine cavity and fallopian tubes. So first, a baseline radiograph of the pelvis is taken. The contrast dye is then injected slowly to decrease patient discomfort. The uterine cavity is filled with the radio-opaque media, and usually about 3 ml is used initially. And we perform multiple pelvic X-rays to visualize the spread of the media from the uterine cavity into the fallopian tubes, eventually reaching fimbriated ends next to the ovaries. The procedure usually takes about 10 to 20 minutes. X-ray fluoroscopy captures real-time images as the contrast fills the uterine cavity and spills into the fallopian tubes. If the tubes are patent, the contrast will spill out of the fimbrial ends into the cavity. A static film should be taken 15 minutes after the installation. What are the alternatives to this procedure? A laparoscopy with chromotubation often helps to identify and to simultaneously treat tubal and non-tubal factors, including intra-abdominal and pelvic adhesions and endometriosis. A hysteroscopy will examine the uterine cavity and exclude the presence of a uterine septum, submucosal fibroids, intrauterine adhesions, or scarring. A sonohysterography is a procedure where ultrasound is used with saline infusion to evaluate the uterine cavity. It may be considered less effective in assessing tubal patency as no objective evidence is generated during the procedure, and the procedure is totally dependent on the operator. Each modality can provide helpful information for assessment of female infertility, but no single study can provide a comprehensive assessment. Thus, a combination of transvaginal ultrasonography, hysterosalpingography, and hysterography or hysteroscopy is required and frequently recommended to evaluate patients with infertility. Hysterosalpingogram offers the advantage of being minimally invasive. The procedure is relatively quick, non-surgical, does not require anesthesia, and can be performed on an outpatient basis. It provides direct visualization of tubal patency and uterine abnormalities. It may even have a therapeutic potential, as the injection of the contrast can open a partially blocked tube. This is also known as tubal flushing. So the question now is that what is the guidance which is provided by the the National Institute of Clinical Excellence, UK, for this procedure. For low and middle income countries where patients have to pay out of their pocket for medical expenses, patients may not easily be able to afford laparoscopy as a first line of investigation. And the NICE fertility guidelines also have this recommendation. They recommend that women who are thought to have comorbidities should be offered laparoscopy and dye so that tubal and other pelvic pathology can be assessed at the same time. Women should not be offered hysteroscopy on its own as part of the initial investigation unless clinically indicated, because the effectiveness of surgical treatment of uterine abnormalities on improving pregnancy outcome rates have not been established. Women who are not known to have comorbidities such as pelvic inflammatory diseases, previous ectopic pregnancy, or endometriosis should be offered at HSG to screen for tubal occlusion, because this is a reliable test for ruling out tubal occlusion, and it is less invasive and makes more efficient use of resources as compared to laparoscopy. Where appropriate expertise is available, screening for tubal occlusion using hysterosalpingo contrast ultrasonography should be considered, because it is an effective alternative to HSG for women who are not known to have comorbidities. There are some associated risks and complications with this procedure, and these include pain and discomfort, which may be mild to moderate during the procedure and after the procedure. Some patients may experience shoulder pain due to referral of pain from the peritoneal irritation by the contrast. There is a small risk of pelvic infection, particularly in cases where there is a past history of pelvic inflammatory diseases, and prophylactic antibiotics may be given in high-risk cases. Other complications include the chances of allergic reaction to iodine-based contrast materials. Radiation exposure is also present, but it is important to avoid unnecessary exposure, especially in women of reproductive age. The American College of Obstetrics and Gynecology recommend that hysterosalpingography should be used and can be done in the follicular phase of the cycle to evaluate the contour of the uterine cavity, the cervical canal, and the tubercle lumina. Other than being diagnostic, it can prove to be therapeutic in some cases. The instrument which is used to introduce the radio-opaque medium should be chosen to give the least discomfort and to cause no leakage of dye from the cervix. Water-soluble medium should be used rather than oil-based medium. Fluoroscopy with image intensification will give the best results. Insufficient dye injection will give an incomplete study. Too much dye injection, especially under pressure, might cause extravasation of the dye into the vascular system or conceal the fimbrial ends of the tubes. This recommendation from ACOG was published in 2005 in the Journal of Fertility and Sterility and can be accessed for further information. If you want to see more images of hysterosalpingography, I will recommend that you go to this publication in 2005, where a very large number of images are given with hysterosalpingogram. With this, we come to the end of the video. If you like this video, then please press the like button, subscribe to the channel, share with colleagues and friends, give your comments, and press the bell icon so you can be notified of future publications. Thank you and goodbye.